Okay, so this is our second panel, which is quite a few experts that we have invited to our clinical and academic panel in precision health from the leading organizations. So I would invite all of our panelists to come in and join us here. And I would like to invite Fran, who is our co-host from HPE, and she is leading the Global Population Health Program over here. So.
All right, we'll make sure everybody is situated and that their mics are good to go, and then we'll get started.
Yes, this is your panel.
This is one distraction I don't need. Okay, shall we get started?
Yes.
All right, wonderful. So I'm really excited to be co-moderating this panel with Archana. You know, it was not too long ago that I participated in an event with the CDC, and one of the things that was commented on was the role that they play within precision medicine, and that they like to believe that all of the work that they're doing, certainly in many examples, exemplifies what is possible with precision medicine. And so today we thought that it would be great to allow the panel to introduce themselves, and at the same time as you do that, share some of the programs that you are currently doing today. So why don't we begin to my immediate right.
So I'm Damon Hostin. I am with the Precision Medicine Alliance, which is a joint venture of Dignity Health and Catholic Health Initiative, two very large hospital systems. And they invested in the Precision Medicine Alliance as a solutions and services company to help understand the way in which biology interacts with all of the facets of the people in their communities. So we own 148 hospitals in 26 states. That's a very large healthcare system, of $30 billion a year in revenue. And so my job, if you look at the sort of social or determinants of health by the World Health Organization, half is lifestyle behavior, access and quality of care, the environment, and about 20% is biology. My job is at 20%. So designing programs around advanced oncology, NICU, undiagnosed networks, pharmacogenomics, and emerging cardiovascular solutions. So I came from Ministry of Genomics, trying to help healthcare.
Fantastic.
Hi.
Yeah.
Hi, I'm Jeffrey Brewer. I am the CEO and founder of a company called Bigfoot Biomedical. And our take on precision health is that we're trying to help dose a pretty tricky drug, a drug called insulin. About 1.5 million Americans as type 1 diabetics are dependent upon insulin to live on a daily basis. Unfortunately, my son happens to be one of them. And about 4.5 million as type 2s are dependent upon insulin as well. And the problem with this drug is there's no fixed dose. You actually have to dose the drug yourself based on a lot of calculations and measurement. And it actually doesn't work too well in practice. It's dangerous. You could take 10% more of the drug at a given dose, which happens between 2 and 5 times a day, and you could put yourself in the hospital, and unfortunately people kill themselves. My son made an insulin dosing error and spent 2 days in the ICU. So this is a really tricky drug, and people need to do a lot of math, a lot of planning. This is not the strong suit of most people, especially when they have to do it every day, many times a day for the rest of their lives. So what we're doing at Bigfoot Biomedical is taking medical grade devices that gather data at point of patient, medical grade and clinically tested algorithms that take that data and then actually make insulin dosing decisions on behalf of the patient, with an infusion pump to infuse insulin automatically in response to this data and the algorithms. If you're taking shots for insulin, to actually tell you how much to take and when to take it. to basically take this data, which today isn't largely captured, and for those that do capture it, isn't largely interpreted, and create a closed-loop feedback system, whether you're infusing insulin, taking shots, to make you as smart as possible in terms of dosing this drug. And it can have a tremendous healthcare economic impact because people spend a lot of time in the hospitals for insulin dosing errors. There aren't enough endocrinologists who can support people with today's complicated devices. And patients live, unfortunately, very compromised lives trying to do all of this. And oh, by the way, this is not pie in the sky. People have done it for themselves, actually hacked into existing insulin pumps and continuous glucose monitor. My co-founder, Brian Maslish, was the first one to do it about 5 years ago. And he did it on behalf of his wife and his son, both of whom have type 1 diabetes. And they've lived transformed lives for the last 5 years as a result of his efforts. This is here as a DIY project, but it's not here yet as a business. And that's what Bigfoot is undertaking to create.
Well, Jeffrey set up what I'm going to say very nicely, and we'll transition here from type 1 diabetes, which is usually a disease of juvenile onset and an immune-based condition, to type 2 diabetes, which is usually an adult onset and begins with insulin resistance. My name is Jim McCarter. I'm a medical doctor and researcher and the head of research for San Francisco-based Virta Health. And our mission is to reverse type 2 diabetes in 100 million people by the year 2025. And the thing that's kind of shocking about that statement is most physicians will tell you that type 2 diabetes is a chronic and irreversible disease. But we actually have shown in a clinical trial with nearly 500 subjects that we can reverse the disease in the majority of our patients. And that we do that not by adding medications, but by actually de-prescribing medications as we make lifestyle, behavior, and nutrition changes. And so in the case of insulin, we're able to reduce or eliminate 94% of the prescriptions. We're actually now showing in our commercial deployments nationwide, we're a nationwide medical provider, built a full stack technology company to be a telemedicine provider nationwide, that we're de-prescribing 77% of the diabetes medications in our patients while they're actually achieving glycemic control off of medication. And so the way that we think about precision medicine are in a couple of regards. One is in terms of individualization of our recommendations. So we're using particular dietary changes, a ketogenic diet, but to make that work for somebody in their life, you can't just hand them a book and ask them to do it. You actually have to work with them, with the medical provider and the health coach and an online community with biometric feedback, and actually give them individualized advice where they can implement that no matter what their life circumstances are. And then you have to react to biomarker changes in real time. So we actually do most of our de-prescription of medications in the first 70 days, and so our doctors are getting real-time information from patients, de-prescribing medications on a daily basis. And then our health coaches, in terms of their prioritization of their patients, are reacting to biomarker changes on a daily basis as well.
Great, I think I'm up here. So my name is Atul Butte. I'm a professor at the UCSF. I run this new Institute for Computational Health Science. Probably most relevant to this audience, I'm the chief data scientist for the entire University of California health system. So that's UCSF, UCLA, Irvine, Davis, San Diego, and Riverside. 6 medical schools, 5 academic medical centers, 15 million patients. That's 5% of the US population. And we have all the medical records in one place now. That's good match. It's working. We have 11.4 billion in clinical revenue per year as a single entity. I'm also the founder of NewMedi, which is computational drug discovery, Personalis, which is cancer genomics, Carmenta, acquired by Progenity, which is pregnancy diagnostics, and I run precision medicine for the state of California. And on very much on the side, I'm a venture partner at Samsung for graphic questions, and a bunch of SAVs. So my new thing, what I think about a lot, what I kind of spend my spare time thinking about is electronic health record data. I think it's old, it's going to be new again, because we've got everyone using it, everyone hates it, doesn't matter, they're still using it. It's not going to get better anytime soon, unless you have a couple billion to replace Epic and Cerner. So they've kind of won the temporary fight. We're all entering all this data in. And so the narrative I like to explain is the entire United States is spending hundreds of billions of dollars installing these systems and rounding error close to zero using any of this data. So I think buried in all of this data is what are the very best doctors doing in the United States when they see these conditions and diseases, what's working in medicine, what's missing in medicine, and what is excessive in medicine. So I spend my time. And I'm also amused. I'm the only one who brought a glass of wine up here. So I don't know what that says. It's not red. They've run out of red. They have literally run out of red. Most of the red is from the
Considering how much work you do, you got it right.
Yes. That could not be a more perfect intro, actually. My name is Hiliary Critchley. I'm the Managing Director of Market Development at Manifest MedEx. So, yeah,
Yes.
perfect.
Yes. Perfect segue.
Exactly. That was not even intended that we sat next to each other. But we are a nonprofit healthcare utility that is bringing healthcare data out of its silos from those EHRs and from health plans, and then serving that up for use cases both at the point of care in clinical settings, but also for population health use cases and care management. So my background is I've done a lot of growth for various organizations, and I'm pretty bullish on where we're going. And it's exciting because we have over 100 providers that have signed up and are contributing data from their EHRs, and we have 4 health plans. The 2 Blues, Anthem and Blue Shield of California, and then 2 Medi-Cal. So we really cover a large swath of the type of population that we have data on. And that is actually how I'm here. The chair of our board, Paul Markovich, met Archana at an event, so passed along the invitation to this. And so what do we do with our 11 million claims and 6 million patients that are covered in our clinical data? Well, you might wonder, precision medicine. My initial take on this was like, I don't know that we're really relevant. It's data. Precision medicine to me is genetics and care pathways. But in understanding the broader perspective of what that means and picking up a few keywords from the earlier panel, it's things like data. It helps cues to drive care for providers more specifically. And how do you augment clinical decision making? And across the care continuum of patients, there's some really basic blocking and tackling that we can be doing with some pretty basic data connectivity. And how do you make that actionable in use cases? And there's a huge ROI that we've actually seen. So what we do with that data is we obviously normalize it, patient match it, database it, and then serve it up in products that we integrate into our clients' workflow. So our clients not only give us data, but we give them back products and services that they can use to decrease costs and improve quality outcomes. So our first product is Notify. So we provide real-time event notifications that are customizable. So when one of your patients is admitted or discharged from the hospital or shows up in an ER and they're attributed to you, maybe as a care manager, as a primary care physician, as an ACO, you'll get a notification. So you can do those things that are required, like do your 7-day visit, prevent a readmission, try to engage to really make those transitions of care meaningful and productive. Access is our second product, and that's a longitudinal health record where anybody who's a clinician and has access to our products can go in and see data across all of our entire warehouse on that patient. So you're able to look at what are the medications that they've not only been prescribed, but then what's been filled in their claims, right? So you can do the med reconciliation. You can see their allergies, procedures, prior diagnoses, kind of across the entire continuum. So it's super helpful, and you can imagine there's many use cases that we can get into. And then Analyze is coming in 2019, but that is really our population health dashboard where you can look across an entire population, segment it, and then really drill down into a specific cohort that you want to manage, potentially for a disease case or some type of program. So I'll leave it at that.
Thank you. My name is Lance Downing. I'm a practicing internist. I was actually seeing patients at Stanford just an hour or so ago. I was actually one of the first clinical informatics fellows sponsored by HP in Atul's old division at Stanford, so a number of connections here. I'm now faculty in biomedical informatics research at Stanford. I work with a research center there called the Clinical Excellence Research Center. We are one of the, I think essentially the only research center in the nation that focuses explicitly on lowering the cost of high quality care. I direct our partnership with the Stanford AI Lab in computer science. And there we're really looking at moving past the precision of electronic health records, because we know most of what occurs in health and healthcare is never even captured, it's never documented. I know what I documented and I noted earlier today about patient care was a poor reflection of what actually occurred, and we don't know many of the nuanced steps that actually contribute to health and healthcare. So we've taken an approach being mindful of things like privacy, usability, to use machines to automatically monitor, detect, and capture what we think are health critical activities. So we're working with folks like the Lucille Packard Children's Hospital, LDS Hospital, and Intermountain Healthcare in Utah, a nationwide leader in quality care, and then some assisted living facilities. And what we're really trying to do is tackle what we think are the largest problems in healthcare, the biggest swaths and pieces of the pie. So for example, we know we have an aging population. We have baby boomers that are rapidly going to be in a phase of their life where they increasingly need assistance. We know that long-term care is both undesirable by people themselves, their family members. It also costs about $100,000 per year, or maybe double that in the Bay Area. So what we're doing there is, again, using this system of privacy sensing, a layer of artificial intelligence, saying, can we automatically detect activities of everyday living that are critical to these people maintaining their autonomy, living safely at home? Could it change your life if you knew your aging parent had gotten out of bed, had gone to the restroom and not fallen down, had gone to the kitchen, opened up the fridge, and was sitting there and watching TV afterwards? Could that change the way that person both ages in home, and then the productivity of that family member who's still working and trying to maintain their own lives? Because we know that about 80% of caregiving done in this country is done unpaid, largely by female caregivers that are usually family members. So we know that there's a drain on society, on the patients, and on their families. And so we're looking towards this type of technology to address this. On the hospital side, wearing my kind of physician hat, we're looking at some of the other big problems that we think are challenging us and we have not yet addressed despite our best efforts. So we know healthcare-acquired infections cause about $12 billion worth of direct costs per year, contribute to the nearly 200,000 deaths attributable to medical errors, and can be significantly reduced by simple things like washing hands. Current state-of-the-art in nearly every hospital in the country, including Stanford Hospital, sadly, is a human being walking around with a clipboard, writing down whether or not someone washed their hands. And as you imagine, that's not scalable, it's not 24/7, and it's not very efficient. So we're applying the same methodology, and we've achieved 99% accuracy in detecting whether or not someone uses hand hygiene when they enter a room. We're now developing the systems to, in a clinician-centric way, provide nudges to do the right thing. We know that alert fatigue is a huge issue, and so we can't just start blaring more alarms. So we're collaborating with faculty in computer science to best understand how do we deliver this information and really change the care. We also have work in an intensive care unit where nearly 3/4% of American GDP is spent every year. We know the sickest patients are there. Nearly 180 individual activities must be done correctly each day for an average ICU patient in order to bring them safely through their course. We know that the human brain is not really designed to perfectly execute on each one of these small tasks, and despite nearly probably 8 or 10 years since Atul Bute's checklist manifesto, we are not executing checklists efficiently in healthcare, despite knowledge that they really work and improve quality and safety. So we're looking, can we automatically provide feedback and detection of things like, was the central line and bundle done correctly? Was each part cleaned? Was it done sterilely? Was this part inserted correctly? And provide that feedback in real time. And then lastly, we're looking at, with collaborators at Intermountain Health, doing this in the operative field. We know that we have world-class surgeons at a number of institutions, UCSF, Stanford, Intermountain, but they're human beings and they get tired, they forget steps. What if we had a system that could automatically detect their tools, monitor their paths, let them know when they're fatiguing, when they're straying from their desired course, and remind them maybe that they forgot a step? Could that change the face of safe surgery? So I'm very excited about all these areas and think these will contribute to the precision in which we deliver healthcare and contribute to the health of aging people.
Thank you.
Hi, my name's Chris Glode. I'm the Chief Product Officer for Helix, and Helix is a personal genomics company where really our philosophy is that everyone should be able to get their DNA sequenced one time and then be able to tap into essentially everything that we know about the genome today at their discretion, along with all of the things that we're going to discover in the future. So it's a partner-driven model where we bring the DNA. We have a laboratory in San Diego where we do exome sequencing, which produces about 30 million base pairs, which is about 100 times more data than a lot of the conventional consumer genomics tests create today. And what that enables us to do is bring a wide variety of partners across health, ancestry, wellness, entertainment and fun, and let them launch products on the Helix marketplace. And we believe that it's a very future-proof approach so that as we start to discover more and more things about the genome, that will enable more products to come to market that let the consumer tap into those innovations. And we also provide a marketplace through our application and through helix.com where customers in the Helix ecosystem can now discover new things as they come to market, so they can be informed of a new test or a new product or a new health report that's available and opt into receiving that. And essentially, once they've been sequenced, that's virtually real time. So while there is a waiting period to be sequenced the first time and submit your saliva kit, that's the way our model works. Is when you buy a Helix product for the first time, we send you a DNA test kit in the mail, you send in your saliva sample, be anywhere between 3 and 6 weeks later we have your result and you can use your first product. As we launch more and more products on the marketplace, you can tap into those the second time and get your results more or less instantaneously. So what we're focusing on now is building tools to let partners launch products faster. So I think a lot of us read in the news, every day, every week, some new study, some new polygenic risk score that identifies something new about us, whether it's our health, our personality, our intelligence, our cognitive capabilities, or even fun and interesting things like how many freckles we have or male pattern baldness. Our vision is that all of these innovations can be brought directly to the consumer in a matter of days. So you might read about it on a Monday that this new score exists, and you might opt in and download a product that uses that on the Helix marketplace at the same time, if not within a very short period of time. So we're extremely excited about the increasing pace of innovation that's happening in the genomic space and really trying to set up a platform that allows all of that innovation and discovery to get into the consumer's hands as quickly as possible. I joined Helix via an acquisition that happened in March, and I started a company called Human Code based in Denver. I've been working in the digital health space for a long time. I worked for MapMyFitness, MapMyRun, and then eventually Under Armour. And as a part of that, I got really curious about genomics and learning how those things impact our health and wellness. And I was in the process of having my second kid, and I got our 20-week ultrasound, and it was a fuzzy black and white photo that I wanted to share out with my family, but I started looking at this and realized this is the same thing we've been sharing out for 50-odd years. And while it serves an extremely valuable medical purpose, it's not the most fun and social experience to share this black and white photo of what looks like a squirrel, at least in my case. So I had just done my first consumer DNA test, and my wife did as well, and I thought, okay, surely there's a product that will give us some way to sort of visualize or imagine what our child could be like based on the combination of our two genomes. And as I looked into it, there wasn't. So I created our first product at Human Code was called Baby Glimpse, and we built a product that lets any two people get their DNA sequence and then combine it to look at it's not a carrier screening test that looks at diseases and health-related traits. There's plenty of those. We wanted to do something that looks at interesting things like, will your child have curly hair or freckles, or how tall will they be, or what will their propensities for different types of athletic pursuits be? So we created that product, and from there launched a couple other products, and we did this on the Helix marketplace because they made it so easy for us as a team of 5 mobile application developers that had no ability to build a lab or no capital to possibly understand how to create an end-to-end genomics platform. We were able to launch on Helix in approximately 4 months, a couple of different applications, and in the process of working with the folks at Helix realized that really our vision to bring DNA to everyone was very aligned. So we joined Helix in March and have now been really working on products to help the consumers better understand the marketplace, because it's not an easy concept for people to grasp that they can have their DNA sequenced one time and tap into things as the ecosystem, as we as people learn more about genetics. And also to let partners, whether they are independent app developers like we were, or even people that have clinical genetic tests today that are sold in the reimbursable market, bring a direct consumer version of those to market, making tools that let them launch those products quickly and easily on the Helix marketplace.
Well, as we are all believers in precision health, but I wanted to ask a question about, in each of your individual field, what are the challenges that you're noticing as we're shifting from the conventional way of evidence-based medicine, and which is much more randomized control trial, to starting to personalize to patients? Damon, you are touching a lot of lives, and of course, Atul, you are the Chief Data Officer for California, so I would want to begin from both of you to see what are the challenges you're seeing for precision health to be truly adopted in its full potential. And we have challenges with the mic.
I think you just start talking.
Yes.
Okay. Yeah, I can talk about it.
Yes.
No, just talking to it.
No, talking to Hill.
Oh, no, turn on.
Yeah.
Okay, so first of all, I think you need to define the scope. So what we heard here was everything from a continuum of the most hyperacute cases in which genomics may be helpful, all the way through to the ability of understanding cohorts within populations to then design programs for management. And it depends where you're coming from. I think Atul and I actually do have a similar lens on this, very large populations. And some of it is about how do we actually take a biologically driven method of treating advanced cancers and matching the therapy to biology, which, by the way, is relatively new. When I was working on steam-powered sequencers at Celera back with, with Craig Venter ages ago, we never imagined you could have population genomics as a portion of assessing risk. So it changed everything when the democratization of the data comes about, and then the beginning to understand wellness as a drive in healthcare. The U.S. healthcare market is very different, of course. It is bizarre. I was just in the UK with Illumina and Genomics England looking at population methods of managing wellness, because it is a capitated type model for many systems. So if you prevent an illness, the total system benefits. I think the biggest issue is shifting from very high acuity care, which is typically the job of big hospitals, into population management. So to get, I would say, the top line boards to understand that a lifetime of risk management is actually worth more than intervening in late stage, highly complex disorders is better. There are some exceptions in NICU and undiagnosed, but there's a cultural shift towards who provides care and why they do it. And there were, in the earlier panel, ways in which you can find these beachheads. And I do think that consumerism is vastly important in connecting the two worlds, but they are different worlds right now. So insurance coverage, core evidence are major, giant blocks. Others are just the psychology and organizational psychology of change in healthcare. I thought when the investors were up in the beginning, one of the best fitness tests they can give their companies is how are you going to approach inertia in clinical decision making. That should be a key question for any of them. So that's a handful for me.
Two.
All right, great. So, I obviously echo a lot here. I think, expert-driven medicine, there are not enough studies, right? I mean, you pick any subtype of any cancer, there's no study. There's probably no company even addressing that, right, with a drug. So, that's one challenge. And so we respond to that. My own belief is that we're going to see, because of the widespread deployment of electronic health records, love them or not, we have a ton of data now, right? We see what actual doctors do. We have the outcomes. They're buried in there, in those records, in free text and images. It's a matter of compute and some curators to get that data out. It can be done. So I think we can really start to figure out this chess game. A lot of medicine, we make a move and we wait for the patient and deceased to make a move, and then we make another move. or whether it's morning rounds or come back to clinic in 30 days kind of thing. And so we can start to see which of these moves actually work or not in this kind of master chess game. Certainly, one complexity of precision medicine and precision health is increasing costs. I think whether it's in the healthy or moderate, mild disease, let's say diabetes, or heavy impact of disease, let's say cancer therapy, the costs are certainly going up. I could spend an hour, we could spend a lot of time talking about whose job is it actually to make sure costs aren't going up. I can't point to anyone in the United States whose job it is to make sure costs aren't going up right now. I would really have to argue the extreme opposite, that there is nobody who wants costs to go down, except for patients
and the payers
and self-funded businesses, which are strangely not at the table because they're not still organized, and I would not agree payers are the way to organize companies right now. So we can discuss that. I also love consumerism, but at the same time, and I love it. I can get my dad's Stanford cardiology reports in the Apple Health app, and I can go for hours on that. At the same time, consumerism only goes so far. And just as a show of hands, I'm going to ask the audience to keep them awake and attentive. How many of you did your own taxes this year, just for show of hands? Okay, so how many of you hired a human being to do taxes? Yeah, oh my God, so there's even more people. This is computerized, it's an engineered problem, the problem of paying taxes. And yet you go find a human to do this. And you think software is going to help you medical side. Okay, fine. Okay, let's take the other example I used. So most of you drive a car, you couldn't have walked here, and there's horrible public transit in Palo Alto, so you must drive. How many of you understand what a check engine light is, right? Right, okay, so so in the United States, since the 1980s, there's an OBD2 port, it's a federal standard. Underneath your dashboard, there's a little cable. If you really bend your neck, you can see that little cable. And if the check engine light comes on, you can buy the $200 gadget to diagnose your own car. So how many of you have this gadget? It's usually 3, okay? So the rest of you are so thinking we're gonna want to self-diagnose ourselves, yet you don't even diagnose your own car today, right? Which is a much simpler problem. Because in the end, you don't want to just know it needs an oil change, you want someone to change the oil, right? And so in the end, it's not like you can write off medicine anytime soon right now. And it's for the same 2 reasons I just gave you. You don't even hire, most of you don't do taxes by software. Most of you don't diagnose your own car. We have a long way to go for medicine. So those are the challenges in precision medicine and consumerism.
Could I challenge that?
Yeah.
All right.
Yes. Please do.
I think there's a difference between an acute crisis and chronic disease. In chronic disease, you actually have the person who lives with the disease very much responsible for the outcomes. And so I would posit there isn't any choice but consumerization. For instance, you might ask why nobody has done what we're doing, which is basically to take data that already exists from diagnostic devices and use feedback loops to drive insulin delivery. And the reason is that medical device companies don't understand consumerism. They understand complicated devices that are built mostly for medical professionals that have quality control and continuing education and only do it for part of the day. But when you give tools to a consumer that has to live with a debilitating disease that they're going to have the rest of their lives, the gracefulness with which it fits into the cadence of daily life, it's much different. We talk about adherence. I think when it comes to chronic disease, we need to get away from the concept of adherence. Apple, when they put out a new feature of the iPhone, they don't say, why aren't people using that? Maybe we need to give them a manual to help them to understand how they could better use it. They make it attractive, they make it usable. And so in what we're doing, we actually put the burden on ourselves to say if people aren't adherent, if they're not doing what they need to do, what we're asking them to do, how do we make it easier? How do we actually design it so that it's easier to comply and to adhere? And again, this is not to compare to an acute health crisis, but chronic disease, I think consumerism is the only way.
So I'm kind of curious about Virta Health too, because here there's a chronic disease that has acuity to it. So if you don't address, don't do it. In Virta Health, you got a condition that it's slow boiling the frog, and there's a lot of hand-holding of doing what a lot of people have tried for type 2 diabetes, and which is truly is a big cost for a large population in the US. What are the challenges you're seeing, and how are you addressing that successfully? What are your success factors that you see?
Yeah. Thanks. So the scale of the problem of type 2 diabetes, 30 million people in the United States with the disease, 400 million worldwide, medical and other expenditures related to diabetes in the United States, well over 300 billion. So you're right. It's this huge problem, and I would tie it back first to, I want to make a comment about precision medicine. I'm also an adjunct professor of genetics at Washington University School of Medicine in St. Louis, and have a background in genomics. But I would posit that what we're trying to solve here is not a genetics question. While there is differential vulnerability to diabetes and to insulin resistance, it doesn't explain why has diabetes increased 9-fold in a generation? Why has obesity tripled in a generation? And that's not a change in our genetics, that's a change in our environment. It's our food environment, it's our mobility, everything about kind of the way in which we live our lives has changed. And so I think that as precision medicine sort of thinks about how to solve diabetes, don't think about solving it from a deep dive into the genetics. Think about solving from addressing phenotype. And so I think that the biggest challenge that we face right now is sustainability. And so what we've been able to do with Virta Health in our clinical trial, and we've now published our 1-year outcomes and are about to submit our 2-year outcomes for publication, is that we've addressed a lot of the skepticism around safety and efficacy. We've shown that you can reverse type 2 diabetes and you can do so safely. Now what we're showing is, okay, this isn't something that people just do for 70 days. This is something that actually works out at a year. So people have lost 30 pounds and are maintaining that weight loss out at a year. They've achieved non-diabetic hemoglobin A1C, and they've achieved it not just at 70 days, but they've achieved it out at a year. And so we're working with our patients on that sort of long-term sustained behavior change. And one of the ways that we've done that, one of the barriers that we've overcome, and it was a decision, a fundamental business decision and business model decision, was rather than trying to provide that intervention through the primary care provider, we partner with the primary care provider to provide them information, but we actually built a full stack company. And so it's our own medical record, it's our own software, it's our own data science, underlying our own providers who are physicians and health coaches that are Virta employees. And the idea is to use the technology to give those care providers superpowers so that they're in touch with the patient 24/7 through their smartphone, as opposed to intermittent visits.
So, there's things that are happening somewhat in a silo, because I'm a provider, a practicing provider, and I'm on Epic, for example. Sorry, Cerner. No, and they do have a whole ecosystem in which they don't know about Virta. They do not know about Bigfoot Biomedical. So I'm going to ask Hiliary the question about how do you make it real for the end user, which is the patient and the provider, because that is where the action happens. And the manifest is trying to accomplish it in some form.
Yeah, sure. Oh, yeah. Thanks. So the way that we make it real is serving up the data through products and services and integrations. So the notifications that we have, that's one of our products, Notify. So basically anytime a patient is admitted or discharged from a hospital or an ER, anybody who's subscribed to that patient gets a notification. So all of the things you have to do for transitions of care, you get an email alert saying, hey, pay attention, you have to do something. Then when you're given that alert, you can then go into the longitudinal record and learn more about that patient. And that data comes not just from Epic and Cerner, it comes from any EHR, because we accept HL7 data from all of our participating providers. And that kind of combination is super powerful. And just to one level deeper is we can actually integrate that longitudinal record back into your EHR so that when you're in a patient care setting, it will just pop up and as a single sign-on, all of that data will be available and usable at that visit. So one very important use case that one of our ACOs has been able to achieve down in Southern California is reducing readmissions by 45%. Which is pretty significant, which also reduced hospital length of stay and increased 7-day visits. And that was across 72 different practices that all had different EHRs. So to us, it's EHR agnostic, and it's kind of the next wave of interoperability is that we're kind of taking this data, connecting it all at the patient level, and then serving it back to physicians to improve care.
45%
so that
within what period of time?
It's pending publication, so I don't have the details, but.
So if you don't mind, so that really brings us back to the decision-making tools, right? One of the areas that we spend a lot of emphasis on or study quite a bit is related to AI. And I think a couple of you touched on that as well. You referenced artificial intelligence and that being a component, essentially a tool that can be leveraged, and genomic data being integrated within that. Would one of you like to comment a little bit about how you've been leveraging genomic data as an aspect of artificial intelligence and decision-making tools?
So the first thing is to be able to have the data for which to either train or have an algorithm or signature go on top of. So that's sort of the first major step. And here was a very simple thing that I was able to get some funding to bring a study in. And it was a personal, not very heavy, but every year on my birthday, I make sure that I have a scan for any skin adenoma, looking for melanoma. Well, I was busy. I didn't have it happen. So I didn't get the screen. So who knows what happened last year. The healthcare system, which is the Centura system in Denver, didn't get the screening revenue, didn't catch me, wasn't managing me. I have red hair and I live a mile closer to the sun than most people. Those are all data pieces that basically need to come together to say here is a cohort, and by the way, the red hair could be genetically determined easily, that would then show that this person needs differential management. Now, are we going to go through and find my job to make all these Damon-centric algorithms to find the better management for me in a perfect system? No. That's where that comes in, to then take a look at what is the acuity around certain markers and how do you raise those cohorts that you can do something about. So just a little bit there.
So Chris, from your perspective earlier, you made a comment about, well, you sort of implied that you could basically select your partner based on how your baby's going to look in the future, right? But what about the relationship between the patient and the physician and how that might be changed in regards to the types of cases that they feel most confident in being able to manage, or how the patient goes about their selection of what type of physician they'd like to help with their case?
Yeah, it's a great question, and just to tap on the AI question briefly, we did a ton of work at Human Code in applying machine learning and neural networks to genomics, and I think that's one of the areas for me where, after hearing it used constantly so many times as a software guy, the first time we were actually able to practice it and create better products using neural networks was in genomics, because the kind of historical state of the art is doing regression analysis against a pretty small number of genetic markers and identifying the ones that have the highest impact. But what we've realized through next-gen sequencing and looking at the whole genome is that most traits tend to be highly polygenic. And so the more traits we can look at, each one having a very, very tiny impact in some cases, but in aggregate have a much bigger impact on our ability to predict things about ourselves. And height is a really simple example. We've known for a long time that the height of an adult human is roughly 80%, give or take, heritable, meaning we get it from our parents, and 20% environmental. Up until the last 2 years, I think the better scores out there could sort of explain 20 to 25% of human height by looking at a few hundred markers. And now with exomes and whole genome sequencing and neural nets, I think the latest one that came out a few weeks ago can predict human height within a few centimeters with a much higher degree of accuracy. So you look at how that can apply to diseases, and it's really interesting because essentially some of these techniques kind of mask us from needing to or being able to understand the biological mechanisms at work, but yet the scores match the data sets that we have. So what will be the standard moving forward when a polygenic risk score using a machine learning based neural network can predict cancer in a certain population at a rate greater than we ever could before, but we can't really explain how or why. And so how will that innovation, which we see happening at an increasing pace, impact how physicians and the medical community and the clinical genetic tests in the treatment and prevention process, how will that manifest is something that I think we'll see explored in a pretty intense way in the coming years.
And how that would interact or be reflected in the way that patients and providers interact with one another? Yeah,
so at Helix, our vision of more or less everyone who wants to having their DNA on file. I think my parents are both physicians and they're constantly carping about how people walk in with their Google search results on their disease that they've self-diagnosed with. I think consumer genomics is taking that to a next level, and that a lot of patients are walking in with their self-diagnosis based on their consumer genomics test. I think that will continue to happen. But at Helix, what we're trying to do is give that genomic data to the customer in a format that they can understand. We try to provide genetic counseling with all of the health-related tests, so if they do have more questions. We certainly don't reveal things to people about a medical condition which they aren't clearly opting in for and wanting to discover. But we're trying to partner with the health systems and the confirmatory tests so that if you got a screen, you feel like you might have a higher susceptibility for Alzheimer's, for example, you can go in, talk to your physician, share your results, and they can recommend a confirmatory test and a treatment path for you regardless of the disease. So we want to give consumers enough information in a very credible way that will allow them to take that into their experience through their health system and in a trusted, well-lit ecosystem where they can bring their data with them, eventually bind it to their health record and let their physician interrogate it without needing to be sequenced again, really provide portability of their genomic data.
So is that a one-time testing that can be accessed multiple times as the person ages or goes through their life journey?
Exactly, but we only look at the germline genome, which doesn't really change, but what does change is we're constantly upgrading our pipeline, so we will reanalyze people's genomic data to give them better and better coverage in different areas as our technology evolves. But our vision really is that we can have one sequence that has enough depth in the right areas to be as valuable as possible, while continuing to deliver the efficiencies where we can get consumers into the platform for under $100 more or less, but give them enough value out of it that they don't have to go be resequenced for every single thing that they might want to learn about themselves.
So that could be potentially integrated into a Manifest MedEx kind of a solution, or in Epic or other. So do you have that integration capabilities in a way?
Yeah, certainly. We're trying to first pull the data in, so we're looking at integrations with Apple and some of the other systems that have been able to connect with Epic and Cerner Health Records. We want to pull that data in so that we can start to enable those discoveries to happen on our platform for customers that have opted in. We're also collecting phenotypic data in a self-collected fashion, but we do envision a world where we will give the patients or Helix members more portability to append their genomic data or their better yet their results into their health records once we can break down the barriers and start to write that information more easily.
So as a practicing provider, how do you like it?
Well, like the genomic data at the point of care?
Yes.
I haven't seen it too often. I've been thinking about some of the comments being made. One thing that strikes me is they all revolve around the service aspect of healthcare, and I think goes to show like the importance of the implementation factors and making it valuable both to the clinicians and the patients. So I look forward to the point where Epic surfaces important genomic information to me that is actionable for the patient with pneumonia that I'm treating, and I can choose an antibiotic based on that. I haven't seen it yet, so I'm looking forward to that. I can imagine this also really changing engagement, particularly in patients with potentially chronic diseases, because those are the patients we already see highly engaged in their care. I think one of the things that I haven't seen people really talking about are how do you engage the long tail healthy majority? You know, we know that the funders of healthcare are the 80% of us that don't have major medical problems. We pay in on a family of four $20,000 into the health system. We take out about $2,000. On the flip side, we know that the sickest 5% use about 50% of the resources, or $100,000 per year. So I think a big question to me is how do you engage that healthy cohort, and how do you prevent them from moving into the 5% and starting to highly utilize care? It's not something they're looking forward to, and us as funders of the health system are not looking forward to. So I think that's a really interesting question. We've looked at a few angles around this, using claims data, for example, to predict who is not going to be a high utilizer soon, but in the next year, so we can then intervene, obviously realizing that only a subset are really intervenable upon. But I think things like that, and understanding the changing dynamics in the reimbursement market are really critical. I think, Atul, to your comment, not sure if the payers are the right way. I kind of agree right now, because right now what happens is Stanford UCSF demands X price, and Blue Shield Blue Cross argues a little bit, but then they say okay, and then they tell Facebook and HP that that's the price, and they grumble a little bit, but then they say okay, and then what we see is stagnation in wages across the country, not maybe here, but on the large, because it's being eroded by the healthcare insurance that we're all paying into our employers. So I think as that begins to become uncovered, or as someone begins to feel that, we'll see that starting to change, and somewhere in that payment arm, there be a voice, and then I think that's when you'll get really strong engagement, and that's when I wonder if the interest in personalized medicine and genomics will really change, and people won't be interested maybe in the things they're interested in now, knowing their risk for male pattern baldness, but their risk for developing something that's very costly that they can then prepare for and change the course of both their health and the financial implications for them and their family.
Lance, I really, pardon me for 1 second, I really appreciate how you were able to bring back the pragmatism to the entire discussion. In particular, we often look at things microscopically, and we think that becomes our bubble in our world. And the reality is that the general practitioner, right, or in the everyday practice, not meaning general practitioner as in primary care per se, or family care, but so much in the everyday practicing physician, it has not yet hit the masses of physicians nor specialists. And I think that that's very important. And I know, Jeffrey, you had a comment you wanted to make. So
I was just going to talk about that topic. I'm sure genomics and artificial intelligence is going to change the world. But we've got a lot of low-hanging fruit right now. Actually, I'll give you an example. My father died of congestive heart failure earlier this year. He was sick for a long time. I bought him a connected scale because I could tell when he was gaining weight, he needed to go and get some fluid taken off his heart. That helped him to live a bit longer and helped his hospital visits to be a bit less intensive. That basic feedback was precision medicine. Sensing a very simple variable, deciding that this is heading in the wrong direction to a very simple algorithm, and then actually getting him to the hospital. We've got so much that's broken in healthcare. The most basic feedback loops are completely busted. So I'm excited about the opportunity to close off those loops before we have to get everybody's genetic fingerprint in the cloud for
Yes. Well, I think it also comes down to where the risk resides. So what you're saying is you were engaged in getting care for your dad or your family from diabetes perspective. So the patient, when they assume risk and get engaged, it becomes a success story. And it's almost like from a practicing provider perspective and from data perspective, I would love to see eventually for us to start seeing who is assuming risk in this ecosystem, in which the data is able to tell that it's the self-insured employer is assuming X amount of X percentage of risk. The patient is assuming X percentage of risk. At the end of the day, it's the end user that starts paying for it. Either it's the payer, which is self-insured employers, the patient, and the providers, because their income stays stagnant. And the system or the administrator for TPAs and insurance companies, they keep on getting the premiums up. So I think risk quantification does become important as you have access to so much data.
I think Damon's lit up on that one. I'm going to let him comment. Yes.
I think that dynamic is key. The other dynamic is who's assuming the risk and then who is paying for it. I think any intervention that's yet to have the evidence to go through the traditional way is and has to be consumer driven. And I think your example is great because it's not approved, so you're not going to get it through your hospital systems necessarily unless there's a specialized program under a protocol. But I think what it also brings to bear is realize that true population health may be very different than precision medicine, and realize if you look at the actual economic numbers, almost nobody has a dispensable $300 to take a chance and invest in their wellness through genomics. I think it was Art Capel, the bioethicist, said, if a few $100, buy a scale, stand on it, and act on the information. So, I'm on like the genome papers, right? So I think you have to be realistic on where we are at this stage of evidence development, and then you start to see risk being managed by different groups, be it walking well populations or hyperacuity. That's why so many of my programs are anchored in hyperacuity.
Jim, what are your thoughts on that? You had some ideas?
Well, I was just going to say that if we're getting better at delivering medical care, why are our cost curves doing what they're doing? Why is the cost going up so much? And there's a graph that I saw a few months back of looking at the United States versus other countries for longevity on the x-axis and cost on the y, or vice versa. And we're just way off where, that we're not getting the boost in longevity that we're getting for the amount that we're paying. What we've done at Virta is that we're super confident in what we're doing. Not only are we seeing reversal of type 2 diabetes, but we're reversing cardiovascular disease risk factors. We published a paper where 22 out of 26 cardiovascular risk factors are showing statistically significant improvement versus 0 out of 26 in the usual care comparator group. So what we've done is we've gone to put our fees at risk. And so we've done a risk-based model. Our early contracts, which are with self-insured employers, half of our fees are at risk based on success at 1 year. And we're now looking with health plans and larger insurers and larger self-insured employers at putting even more of our costs and fees at risk.
Yeah, one more comment here.
All right, so I've been silent for most of it. So I love startups. I love type 2 diabetes. I'm technically a pediatric endocrinologist, but everything is great for like a Silicon Valley type population. Remember, a third of population in California is on Medi-Cal, so they're really they're lucky to have a smartphone, right? So all of that. So we have to understand, not all health systems see those patients. Right? It's very easy to draw from the numbers that don't see those folks, and then extrapolate thinking everyone should be as efficient. There are a tough number of patients in California and even in Silicon Valley that don't have a home, right? And so we're trying to figure out genomes, and I'm on the advisory board for Helix, so I love them too. Why aren't costs dropping? I mean, so my kind of truisms here, and for a Silicon Valley audience, it's so easy to look at healthcare as from the engineering mindset. And so the engineer looks at healthcare, this decrepit system, which isn't even a system, and thinks of it as gears that are incredibly rusty. And you think, oh my God, if I just add oil in a couple places, these gears will turn more efficiently. It's so tempting to think of healthcare. Friction is the wrong model for healthcare. It's resistance, right? Nobody is burning money on the front lawn of the hospitals. Every dollar of the $3.2 trillion economy is made by someone. Every time you think you're going to save money, you're taking it away from someone. There are going to be fights. You have to pick those fights early, figure out who's on your side and who you're going to fight. It's not all kumbaya. We love each other. We're having drinks together. But we're competitors in the system too. And so the earlier you realize that and pick the right fights and figure out whose side you're going to be on, who you're going to go up against, that is the reality that is under the table here, right? Stanford competes with UCSF, UCSF competes with Stanford. We both kind of love and hate the payers, right? And so you have to realize that it's not just a matter of adding oil, that you have to pick and realize who has the dollars. It's strange, so my worldview of medicine now is it's a triangle where you have device and pharma at one corner, payers at one corner, and providers at one corner. And usually two of these are ganging up on the other one with the blame. And in any article, payers and pharma will gang up on providers. Providers will gang up on payers, right? And strangely, missing in the triangle are patients and self-insured companies, which are powerless and voiceless right now. And when you really think about it, no one in this triangle is actually incentivized to cut costs. And nobody in the triangle has to cut costs. So if you want to really reinvent things, you're going to have to pick fights, pick a bunch of allies, and really disrupt these corners here. Because nobody here, actually, people are making every dollar of the $3.2 trillion system. Start with that.
We'll let Hiliary have the last word. And then
well, I would add government as another, I mean, we're in healthcare. It's a major player.
Self-insured, yes.
So,
but a player
I mean,
nonetheless.
and I think that, to your original question, who's bearing the risk? I think the government has played a huge role in value-based care, ACOs, creating incentive models, Medicare Advantage, in California Medi-Cal, shared risk programs, bundled payments. I mean, all of this is not a majority of healthcare spend, but of course I think it's a step in the right direction. And I think that to be successful, we're finding out what works and we're figuring out what data is needed to be shared by whom, when, how, and at what point to really make an impact to drive that forward so that it can be expanded to a broader population. So I think your point about who bears the risk is essential, and in our free market economy, it's really important to just remember kind of healthcare as a policy-driven entity in this country as well.
Absolutely. So we have come to the end of the day, but I would say that it's been a dynamic discussion, in particular acknowledgement of a very diverse and often at odds in regards to our ecosystem. The utility of the data, you have all proven the utility of the data and just given us glimpses of where we can go into the future. And then certainly, although it wasn't outrightly spoken, a little hint on the ethics related to this as well, and rights and access to data. Archana, don't you want to ask add last couple few final remarks?
Yeah, absolutely. So I think as we're closing the panel today, we're also looking at the horizon in which we have unique partners that are emerging. So we're looking at Google doing their health cloud, and of course Microsoft doing their health cloud too, where data can start flowing and maybe remove some of the costs that the health systems are incurring to store their data or own their data. Maybe that could be a way for us to shave off some amount of cost from healthcare in general. We have many more stealthy players that are getting into the market. The fruit company and the retail company included. So there is a lot that's happening on the horizon, and hopefully the next year when we do this panel, we may have some unique applications and solutions that we would be talking about. So with that, we can close. Anybody has any questions? Or,
we just want to make one reminder of the next panel, which I forgot the title of.
Vitality.
But what was the title we gave it?
Lifestyle.
Lifestyle as a drug, I think is the title. And that's coming up in December.
Yes.
Bambi, remind me of the date. Thank you. I couldn't. December 13th. There we go. So thank you all for coming out tonight. We hope you did enjoy it and look forward to seeing you next time.